diabetes. I assume by now all of you have done rotations. You've had a diabetic patient of some level, right? Very common disease nowadays. What is it a disease of? It's an endocrine disease, right? Usually it's caused by insufficient insulin in the body or no insulin in the body. Insulin's produced from the pancreas. Insulin provides sugar to the cells, and sugar mixed with oxygen is what provides energy to the body. Okay? So glucose, or sugar, is required as fuel for cellular metabolism. The brain's need for glucose parallels its demand for oxygen. So we've talked about airway and whatnot and how you need oxygen for the body to work and whatnot. The brain needs oxygen. Well, the brain needs equally, it needs sugar. Okay? So here's the pancreas. It's located in the retroperitoneal space. What does that mean? Retroperitoneal.
Behind the
right.
thing.
So the peritoneal space is the abdominal cavity. Retro means that it's in the backside. So picture it as basically behind the stomach. Okay. So your stomach's in front, and then the pancreas would be behind it, almost exactly under your xiphoid process, but towards the back. Produces and releases digestive enzymes into the duodenum, which is part of the intestine. Insulin, glucagon into blood. Okay? And insulin and glucagon are the two hormones that we need when we talk about diabetes. So the islets of Langerhans, alpha cells, glucagon raises the blood sugar. Beta cells, insulin lowers the blood sugar. Okay? So you don't really need to know that term. Just know that glucagon raises blood sugar, insulin lowers blood sugar. How does that do that? It gets the sugar out of the bloodstream into the cells. Okay? Or in the case of glucagon, it gets it out of the cells into the bloodstream. So insulin, it's a hormone produced by the islets of Langerhans in the pancreas. You just need to know pancreas. Okay? Required for sugar to enter most cells, not all cells in the body, but most. Brain does not require insulin to use sugar. Okay? So the brain does not require insulin to use sugar, but most of the rest of the cells in the body do. Okay, how does insulin work? Like, what does it do to help the sugar out? Think of it as a key. Okay? And what it does is it unlocks the door and lets the sugar in. Sugar is or dextrose, is a very large molecule when we talk about things on the molecular level. Okay? So we're talking about cells and all these micro-sized things. Sugar is a very large deal. Okay? It's very, very big. So it needs some help getting into the cells. So diabetes mellitus, or DM short term is how we put it, is a metabolic disease characterized by inadequate or absent insulin production. Type 1 diabetics, no insulin production at all. They have to take insulin injections, and typically is juvenile onset. So it comes on at a younger age. Okay, type 2 diabetes is inadequate insulin production, increased tissue resistance to insulin effects, can be controlled with diet and oral medications such as diabeta, diabinase, whatever. Glucophage is a common one, oranase. Insulin injections as the disease progresses. Okay, so this is the one that occurs later in life, caused by poor eating habits, obesity, maybe genetic. Problems in diabetes. So most diabetics that we find, the first time they have a problem, it's because their body has stopped producing insulin or has slowed down the production of insulin. What does insulin do? It gets sugar out of the bloodstream, right? If you stop producing insulin, what do you think the level of sugar in your blood is going to do? Go up. So that causes hyperglycemia. And there's two types of hyperglycemia that we see. The first one is diabetic ketoacidosis, or DKA. This is the problem that most diabetics will present with the first time they have an episode. So they'll be found unresponsive or whatever at home because they have high blood sugar, and that's how they find out that they're a diabetic. Okay? And then HHNC is hyperosmolar hyperglycemic non-ketonic coma. Okay? HHNC, yeah, and then hypoglycemia. Okay, hyperglycemia causes failure to take your insulin. So in a diabetic patient who knows they're diabetic and is doing insulin injections, if they stop taking their insulin or forget to take their insulin, obviously their sugar is going to go up. And then they're going to be hyperglycemic. Or overeating or eating the wrong diet. Someone who does not know that they're a diabetic, obviously they're going to be eating normal or whatever they want, and they're going to go into hyperglycemic. And stress on the body, fever, infection, or emotional stress can change the way the body uses the insulin or the amount of insulin that their body needs. And if they're not regularly checking their sugar can creep up on them. And again, new onset diabetics usually present with an episode of hyperglycemia. Diabetic ketoacidosis. So you guys, when we talk about diabetic patients, the first thing you're going to want to determine, is this a high blood sugar problem or a low blood sugar problem? And if it is one of those, what's causing it? And what can I do about it? Okay? So DKA, usually a type 1 diabetic, someone who has no insulin. Okay? The blood sugar rises, kidneys try to remove excess sugar, so the body tries to fight off this sugar. Urine production increases, so they have polyuria, they start peeing a lot. Patient becomes volume depleted because they're trying to pee off all this extra sugar that they're getting. So then they get thirsty, polydipsia, which allows them to pee more, but eventually they get behind because they can't drink enough, so then they start going into shock. So they get tachycardic, hypotensive, and they will present with dry skin, dry mucous membranes. So they will go into hypovolemic shock, secondary to elevated blood sugar. Okay? The body cells cannot burn sugar. Okay? So patient experiences hunger, so that because the body is sending signals of we need sugar, we need sugar, we need sugar. So they're going to want to eat because they feel like they need sugar. The cells burn fat as an alternative fuel. Acidic ketone bodies are produced as a byproduct of burning fat. Patient tries to correct the acidosis and exhale CO2, which causes rapid deep breathing, what we call Kussmaul respirations. And the exhaled ketone bodies produce a nail polish remover or fruity breath odor. Okay, so remember a little bit ago I said it's not just alcohol that you will smell for on a patient's breath. Okay, well, in someone in a diabetic coma, you're going to smell their breath, and if it smells kind of sweet or fruity, it may indicate that they're in DKA. So they go into shock from volume depletion, and they'll have fruity odor, rapid respirations due to the ketone body production. And that's how you know they're DKA. And their sugar will read high, which what is high? Usually over 400. And your glucometer, most glucometers somewhere between 5 and 600, so 500, 550, or 600. It will stop giving you a number and it will just read high. However, the actual lab at the hospital will get a number, and it's not uncommon to have someone in DKA with a blood sugar of 8 or 900. Or I've seen a few over 1,000. Okay? HHNC, or hyperosmolar hyperglycemic non-ketonic coma. The difference here is that these are type 2 diabetics, so they do have some insulin in their body. And because they have some insulin in their body never burns the fat for a need for sugar. It never gets that bad. Does that make sense? And since it never quite gets that bad, even though it throws them into shock the same way DKA does, they don't ever produce ketones, so they won't have that real fruity smell. Okay? So same things here. Kidneys try to remove the sugar, causes polyuria, patient's volume becomes depleted. Same signs and symptoms. They're going to present hyperglycemic. That's what you're going to pick up on. You're going to check their blood sugar, and it's going to read high. The only real way that we can tell is history. Are you a non-insulin dependent diabetic, or do you take insulin? Because that'll tell us right there. And then you can smell their breath and try to pick up on the ketones. Okay? Our treatment doesn't change. We're still going to treat them for hypovolemic shock and try to lower their blood sugar. Okay? HHNC, severe volume depletion, no ketone body production. But they're both hyperglycemic patients, and you're going to treat hyperglycemia the same way, regardless whether it's DKA or HHNC. However, on your test, remember DKA has the fruity odor, and the history of whether they are insulin dependent or non-insulin dependent will help you determine whether it's DKA or HHNC. Okay? Hyperglycemia management, support the ABCs, treat for hypovolemic shock, transport the patient. When in doubt, give sugar. Okay? When in doubt of what? Okay? So let's say you find a patient who is diabetic, but you don't have a glucometer because you're off duty. And you don't know if this is because their blood sugar is low or because their blood sugar is high. Okay, or whether you know whether they're a type 1 or a type 2, because if they have some insulin, the sugar might work. Okay, if you're able to give them sugar, that's fine. If it doesn't work, it doesn't work. Giving someone who's hyperglycemic a little bit of sugar is not going to harm them in that their sugar is already high. Okay, it's not going to make it that much higher. However, if the problem was that their sugar was low, it may help them. But again, on the ambulance, you're always going to have a glucometer. You're always going to check their sugar, so that won't be a problem.
What would be on the glucometer considered like a low sugar?
So we treat under 60.
Under 60.
Under 60. But normal is 80 to 120. So we treat, definitely if it's under 60, we can treat anything under 80 with signs and symptoms. But definitely, I usually hold off until they're under 60. And I've had people at 53 and, whatever. The highest I've seen was like 1,030.
Oh my god.
Okay.
How?
It's a lot of sugar. Okay, hypoglycemia. So this is low blood sugar, right? Causes insulin overdose. So people who are insulin dependent inject themselves with too much insulin, or they take a normal amount of insulin, but they don't eat so that it has too great of an effect on them. Or they take their normal amount of insulin and they decide to go exercise and they burn up all their insulin. Okay? So there's a lot of, there's a big balance there with what these people can do. So people who are diabetics and are on insulin, they can live pretty much a perfectly normal life as long as they keep the balance. Okay, but they have to watch it all the time. They have to check their sugar 2-3 times a day. They have to watch what they eat, and they have to learn what they eat and how it affects their body. And eventually it'll change. They may take 40 units of insulin every day. Sooner or later they'll see that their sugar starts creeping up, and they'll have to start taking 60 units of insulin every day. Like, it will snowball. So hypoglycemia, blood sugar falls. You got two kind of different things that go on. The brain lacks adequate glucose, so they have altered level of consciousness, which can cause seizures, headache, and unusual behavior. Sometimes they can be kind of violent, or they won't be able to follow commands. Adrenal glands release epinephrine because the body is stressed out. So then they start showing you signs and symptoms of shock, right? So pale, cool skin, sweating, tachycardia, increased blood pressure, and nausea. So we call this a diabetic coma or diabetic shock. Okay, is it really shock? The answer is no. It's not really shock, but it looks like shock because of the release of epinephrine. Okay? However, we know that it's not shock because we walk up, we give them some sugar, and all of a sudden they're perfectly fine. Okay? Shock, they would actually be having a problem. Now, can you die from your blood sugar being too low? Absolutely. Okay? It can cause heart attacks. It can cause the brain to starve of oxygen and sugar. You know, it can have some serious problems. Okay? However, usually as long as we get there in time, these people, we give a little sugar to them, and they're fine. So, again, insulin shock, diabetic coma, diabetic shock, whatever you want to call it. Is it really shock? Not really. It's altered level of consciousness, easily reversed. However, hyperglycemia can cause hypovolemic shock. Okay, high blood sugar, you will pee off, you will vomit your fluids out. So insulin shock isn't really shock. Patient just looks shocky because of the epiadrenals are being released. Can occur in non-diabetics. Okay, so hypoglycemia, low blood sugar. You or I can get low blood sugar. Okay, you've all felt general malaise from being up all night and not eating right. Okay, most common cause of low blood sugar is alcohol on an empty stomach. A patient is never just drunk. Okay, so you go to the bar, guy fell off his bar stool and say, he's had 2 shots of whiskey and about 6 beers. Okay, check a blood sugar, check a blood sugar, check a blood sugar, because there's absolutely a good chance that the sugar will be low.
And in that case, you just give them sugar also?
Give them sugar, feed them. And it's not necessarily sugar. So when we want to increase somebody's sugar, it's, you guys carry some glucose in your tackle box or whatever that you can give some quick oral glucose. They need food, specifically carbohydrates. The body breaks down carbohydrates and turns it into dextrose or sugar. Okay, and it's a long process, and it like an example, a piece of bread. Okay, bread when it gets broken down in the body is straight sugar. Okay, it's going to break those complex carbohydrates into simpler carbohydrates that eventually become sugar. So bread takes a little bit to digest. So our classic diabetic food is a peanut butter and jelly sandwich. Okay, the peanut butter, it's all complex carbs. It takes a while. So we'll give them the syrupy sugar right away that they can kind of suck on and whatnot. It gets absorbed. And that oral glucose you give them, they're supposed to suck on it. Okay, not just swallow it, because it gets absorbed right through the mouth into the bloodstream. They'll start seeing improvement. And then once they can eat, make them a sandwich. We make scrambled eggs, peanut butter and sandwiches, whatever it is. We'll spend an hour at their house. We'll cook them a gourmet meal if they want it, wash the dishes, put them away, do whatever we can to make them comfortable. But usually it's a PBJ with orange juice, apple juice, whatever they want to drink. And we'll stick around for 30 minutes or so, check their sugar. My test for a diabetic on whether I can leave them and they're okay is we talk to them and we establish everything, but I make them demonstrate to me that they can check their own blood sugar. Okay? And they show me that they understand how to work all their equipment works, they know where it is, they can comprehend what I'm asking them, and they can physically check their own sugar, do their own thing. Then I say, okay, as long as you can do that, you understand what happened today, you want to stay here, that's fine. Okay? We always offer transport. Most diabetics won't want to go because they're familiar with the process and what they need to do. So I make them, answer all my A&O type questions. You know who you are, where you are, what's going on. And then can you demonstrate to me, do you have all your equipment? Do you have everything you need? And if they have everything and they can check their own sugar for me, then I'll let them sign a refusal. Hypoglycemia management, conscious patient, give sugar orally or have them eat. A lot of time people will, let's say they go to the outlet mall and they're walking around and they're didn't bring enough snacks or whatever for lunch, but they don't want to eat any of the junk food at the food court or whatever it is, and their blood sugar gets low and they get a little bit weak, and the store manager calls 911. Okay, so we go out there, we'll go to the food court, and we'll just ask the people, hey, can I get a Diet Coke and a hot dog? And they'll usually just give it to us, and we'll have them eat it right there. Okay, and that hot dog, same thing, complex carbs, a lot of sugar in a Coke, and they're fine. Or it'll happen at a gas station, and we'll just go in and we'll say, hey, can we have a candy bar and a Coke? And they'll give it to us and we feed them and we're good. And they don't usually charge us for that type of stuff. Same thing if you go to a football stadium for a ball game or whatever, grab the vending guy and say, hey, we need a hot dog and a nacho and a Coke. And okay, and usually they're real good at those type public institutions of they'll just give you kind of whatever you need. Yeah. So conscious patient, give sugar or food orally. Unconscious patient, support the ABCs, get ALS backup for IV glucose. So we're going to start an IV on them and give them sugar that way. When in doubt, give sugar. Again, in order for you to give them anything by mouth, what's the test I want you to do? Give them a drink of water. Okay, and if that causes them to really cough and gag and causes a big problem, then don't put anything in their mouth. If they're able to drink the water just fine, then put something in their mouth. Okay. Ask all diabetics, have you eaten today? Have you taken your medication today? When in doubt, give sugar. Okay. Other diabetic complications that you have. So because they're diabetic and their sugars are funky and whatnot in their blood, it causes atherosclerosis, which is a hardening of arteries and the plaque buildup, which leads to more frequent MIs, strokes, blindness, renal failure, peripheral vascular disease. They're going to have diabetic neuropathy, what we call it, where it affects the nerves in their legs and whatnot. They can't feel as well. They're going to develop ulcers on their legs. Diabetes really leads to a poor end for just about everybody. A lot of time they'll get their toes amputated and then their foot and then their leg at the knee. It's kind of sad. Gangrene, that's that necrosis of the legs or whatnot. Any wounds, owls, nicks, wounds that they do get heal slowly. It's more difficult to heal for them because of the poor circulation and whatnot. Increased silent MI risk, especially in female diabetic patients.
What's the silent MI?
It's one without chest pain. Silent MI, acute MI in diabetic can present without chest pain, may resemble the flu. Manage sick diabetics as if critically ill until proven otherwise. Okay. Any questions about diabetes? What's the difference between type 1 and type 2?
Type 1 is when you're young.
And type 2 is what? Okay. So type 2 is mainly diet controlled with oral medications and eventually will lead to insulin. And type 1 is no insulin and insulin injections from the get-go.